I'm Dr. Ann McIntyre, and I'm a Karius medical director, and I wanted to give a brief overview of the Karius test before we move on to the presentation by Dr. Benamu. First off, we understand that infections are a leading cause of morbidity and mortality in the immunocompromised patient with a notable mortality rate. More specifically, among the immunocompromised are those with cancer. Unfortunately, a large number of deaths in cancer patients are related to infections. Diagnosing infections is challenging in the immunocompromised patient. There are clinical signs of infections that can be subtle and atypical. Furthermore, polymicrobial infections may be at play, including not just bacterial infections, but also viral or fungal infections in the same individual. While quite valuable for both diagnostic and therapeutic purposes, bronchoscopy and other invasive diagnostic procedures may not be feasible in many patients, with literature noting a variable success rate in achieving a diagnosis, with further concern regarding risk of morbidity. The Karius test is a blood test based on next-generation sequencing of microbial cell-free DNA. Over 1,000 detectable pathogens from a standard blood draw may be detected with a rapid turnaround time of approximately 1 day from receipt in the CLIA-certified CAP-accredited lab. The Karius test was developed based on the observation that as pathogens grow, divide, and turn over, they spill traces of intracellular DNA into the plasma. If you take that plasma and remove human DNA, you can sequence everything that's left behind to identify DNA-based pathogens, including bacteria, DNA viruses, fungi, and parasites in one test. Essentially everything except RNA viruses. This concept isn't new. It's already transformed other areas of medicine, including non-invasive prenatal testing, and can also look for cancer DNA in the bloodstream. And now through Karius, microbial cell-free DNA is being used for infectious disease. Because we are a blood test, people often think we only detect bloodstream infections. However, we are able to detect deep-seated invasive infections anywhere in the body. Stated another way, circulating DNA from dead or dying pathogens is a signature that can be used as a true liquid biopsy, where infections almost anywhere in the body can be detected using a blood sample, accurately, non-invasively, and rapidly. The sample is collected on-site in a PPT tube or K2 EDTA tube. It is sent by first overnight shipment to our CAP-accredited CLIA-certified lab, and microbial cell-free DNA is then extracted from plasma and NGS performed. Human sequences are removed and remaining sequences are aligned to a curated database. Organisms present above a predefined statistical significance threshold are then reported. Reported organisms are quantified in DNA molecules per microliter, or MPMs, as compared to a reference interval determined from 167 asymptomatic donors. Now, in addition to a report, Karius also has several pediatric and adult infectious disease physicians available for consultation, as well for any questions, either pre-test or post-test. And to sum up, several publications have noted how the Karius test may improve the diagnosis and management of life-threatening infections via the speed to diagnose infection, impact on antimicrobial management, and usage of invasive procedures. Now to discuss her study publication, the Plasma Microbial Cell-Free DNA Next-Generation Sequencing in the Diagnosis and Management of Febrile Neutropenia, I have the pleasure of introducing Dr. Esther Benamu. She is currently an assistant professor of medicine for the Division of Transplant Infectious Diseases at the University of Colorado. She is an author of multiple publications on infectious diseases in transplant recipients and immunocompromised hosts. She completed her postdoc fellowship in immunocompromised host infectious diseases at Stanford Hospital, Stanford University, and she obtained her fellowship in infectious diseases at Montefiore Medical Center, Albert Einstein College of Medicine. Dr. Benamu received her medical degree from the University of Barcelona, Spain. Dr. Benamu, I leave the mic to you.
Thank you so much, Dr. McIntyre, for this kind introduction, and thank you to the organizers and Karius for inviting me to present this data. Well, first I'll start saying, this study was funded by Karius, but I have otherwise no really clinical, no conflicts of interest. So I'd like to start just sort of going over a little bit what Dr. McIntyre has already explained, is the challenges that we infectious diseases doctors and transplant infectious diseases doctors have in the management of febrile neutropenia. Fever is frequent, and it's a frequent complication of chemotherapy-induced neutropenia in patients with hematologic malignancies. And the etiology is believed to be infectious in most of the cases and really caused by a very broad array of microorganisms. But classical microbiology, notably blood cultures, often fail to identify a pathogen. So consequently, what happens, we end up treating empirically with antimicrobials for very prolonged periods of time. These remain unfocused and often inappropriate, and of course are associated with adverse events. And even if the emergent nucleic acid-based strategies can really identify non-culturable organisms and are an advancement and are less impacted by prior antimicrobial administration, yet they're still limited in terms of the range of detectable organisms. So I'll use this example just to illustrate this sort of challenges that we face clinically, to talk about a case in which Karius test was not used and could have. This is a 52-year-old female who presented with fever, encephalopathy, and a total of 13 brain abscesses up to 2 centimeters in her brain, and a 2-centimeter lung nodule that surrounded with granulomas in her lung, as you can see in the images. Now, she did get a core needle biopsy of the pulmonary nodule, but it was pretty unrevealing in the histopathology, and then the cultures, bacterial, fungal, and AAV cultures were negative. There was discussion on doing a lumbar puncture, but she had too much of cerebral edema to perform this. And then the brain tissue biopsy was also considered of high risk because of her risk of bleeding, and then eventually was later deferred as well. Needless to say, she had negative blood cultures and a bunch of other ancillary testings, including fungal markers, toxoplasma, blood PCR, IgG, and such. So what ended up happening is that we did not have a microbiological diagnosis, and she ended up receiving empirical treatment for things like bacterial organisms, nocardia, and fungal organisms with meropenem, linezolid, Bactrim, and Cresemba, abuconazole. So, and in total, she received more than a year of empirical treatment. Luckily, her serial brain MRIs showed improvement, and we were eventually able to de-escalate a little bit the therapy, but it was very much associated with multiple drug toxicities, and we had to switch around treatment many times. So this is a case in which a non-invasive, sensitive, broad, and unbiased diagnostic tool such as Karius test could have certainly been useful. So what we tried to do with this test was to look into examine the performance of Karius test in the etiologic diagnosis of febrile neutropenia in adults with acute leukemia. Our primary objectives were to look into the performance of the test at the time of enrollment and at time of fever onset, and compare it to that of blood cultures, as well as a composite reference standard of conventional microbiological diagnostics, radiological studies, and clinical adjudication. Our secondary objectives were to look into the performance of the test at subsequent testing, look into the time of diagnosis at T1 for relative to standard microbiological testing, and also the potential impact that real-time Karius test results could have had on the antimicrobial management at T1. How did we do this? We conducted a prospective observational study at Stanford University Hospital that enrolled 57 patients with acute leukemia and neutropenia defined as less than 500 neutrophils per cubic millimeter, and fever based on definitions by neutropenia guidelines. Karius test samples were collected within 24 hours of fever onset and every 2 to 3 days up to 5 times or until neutropenia resolved. Then Karius test results were compared to those of initial blood cultures, as well as the composite diagnosis of standard microbiological testing performed within 7 days of enrollment, radiographic tests, and clinical adjudication by 3 independent infectious diseases physicians. Now, it is important to mention that at the time of the study, Karius test was only validated as a qualitative test, and that all study results were blinded to the study team as well as the care providers. When we looked into the comparison of Karius and blood cultures, a true positive was defined as the concordance and the positive agreement of blood cultures and Karius test, true negatives, the opposite. A discordant positive was when a Karius test was positive, but the blood culture was negative. And a discordant negative was when Karius test was negative and the blood culture was positive, that is excluding contaminants, or when both tests were negative, with positive, but with different microorganisms. As for the adjudication, the committee defined a definite case when Karius test result was concordant with at least one pathogen identified by standard microbiological testing and was a cause of febrile neutropenia. A probable case was in cases of Karius test positivity and negativity of the standard microbiological testing, and the pathogen detected by Karius was a likely cause of febrile neutropenia based on clinical, radiologic, or laboratory findings. A possible case against was a discordant case, and in this situation, Karius test would be consistent with infection, but not a common cause of febrile neutropenia. An unlikely diagnosis was when Karius test would be positive and discordant with a standard microbiological test, or not a plausible cause of infection, or really there was an alternative etiology that was more likely for the fever. A false negative was deemed when Karius test was negative, but a standard test was positive, or all tests were negative all across, but there was a suspicion for infection on the basis of clinical grounds. True negatives were those in which there was concordance negativity and or the fever was really attributed to a non-infectious etiology. And finally, indeterminates were those in which there was insufficient data to classify the case. So overall, we enrolled 57 patients, 8 of which were discontinued from the study, and 2 were excluded from the analysis because of poor sample collection. So we end up having 55 patients in the modified intent to diagnose group. Most of our patients were male, 56.4%, with a mean age of 55 and a median age of 60. Most of them had AML in 70.9% of cases. There were 3 stem cell transplants, of which actually 2 ended up being excluded from analysis. 60% of patients had some sort of other chronic medical condition. And importantly, at the time of enrollment, 71% of them had some sort of antimicrobial on board. 34.5% had antibiotics, and 4 of these cases were on levoquin prophylaxis for neutropenia. 20% were on some antiviral, and 16.4 were on antifungal, mostly prophylaxis. So this flowchart really summarizes our enrollment and overall results at T1. So from the 55 cases that we included in our modified intention to diagnose, 9 patients had positive blood cultures and positivity of Karius test. There was 1 case in which it was a discordant result between blood culture and Karius test. 31 cases of positive Karius test and negative blood culture, and 14 cases of negativity all throughout. Once clinical adjudication happened, the committee determined that the etiology of fever was infectious, so there was a clinical diagnosis of infection in 48 patients. 41 of these had a positive Karius test result that was deemed a plausible cause of infection. And from these 41 cases, 12 were classified as definite, 19 as probable, and 10 as possible. There were 7 cases in which Karius test was negative, but there was a clinical diagnosis of infection suspected. Only 2 of these cases had actually positive standard microbiological testing, and this was specifically a case of a positive Prevotella culture on a tooth abscess and a positive Aspergillus niger on BAL that we will discuss a little bit later. There were no cases in which there was a false positive Karius test determined by adjudication. And finally, there were 7 cases of concordance of negative clinical diagnosis in Karius test. So how does this translate into the performance of the Karius test at a time of fever onset? To the left, we have the comparison of Karius test and blood cultures. That translated into a positive agreement of 90% and a negative agreement of 31%. And this is because in 31 of 45 cases, we had a positive Karius test. So Karius found an organism that blood cultures did not find. Now, I'd like to talk about this little 1 case in here in which the blood cultures were positive and Karius test was negative. This was a case in which a single blood culture was drawn and resulted as a Streptococcus parasanguinis. This blood culture was drawn about 24 hours before the patient actually met criteria for fever based on the protocol. About 48 hours later, the Karius sample was drawn and detected herpes and herpes simplex 1 and Provotella oralis. So possible explanations for this discordance were that either the blood culture was a contamination, as it was only detected in one blood culture, or that the time elapsed between the sample collection allowed for the antibiotics to work. Now, once we did the clinical adjudication to the right, we see the comparison of Karius test and clinical diagnosis. Again, this translated into a sensitivity of 85.4% of the cases. 48 cases were deemed to be caused by an infection. And of those, in every single case that Karius test was positive, there was a plausible cause of infection based on adjudication. Of these cases, as I mentioned before, definites were 12, probables 19, and possibles 10. I have to mention that, as you can see here, all the possible cases were classified as true positives. And then there were 7 false negatives, of which, we talk about here a little bit briefly, 2 cases of clinical cellulitis, 2 tooth infections, 2 cases of pulmonary nodules, and 1 case of persistent neutropenia of unclear etiology that was transferred to the ICU. And again, of those 7 cases, only 2 had positive standard microbiological testing. And then finally, 7 cases of, 7 true negative cases resulting in a specificity of 100%. These were, these true negative cases were 5 were deemed not infectious etiology, and 2 of them were cases in which an RNA virus was detected. And again, by predefined criteria, Karius cannot detect RNA viruses. So if we look at the microbiology specifically at the time of fever onset and overall the results, so we had 10 positive blood cultures and 75% of the Karius test results were actually positive. In 61% of these were polymicrobial results. And truly it was mostly GI syndromes that were clinically significant, such as neutropenic colitis, diarrheal syndromes, biliary infections in these cases. The most frequent pathogens detected by Karius at T1 were essentially E. coli at 10%, then herpes in 8 patients, in 4 of which there was a confirmatory PCR later on done by standard testing. Then gram-positive such as strep mitis, enterococcus, staph aureus, rothia, and gram-negative such as Pseudomonas aeruginosa, Bacteroides. If we look at overall all time points, about 85% of all Karius test samples were positive, and the predominant bacteria were again kind of similar organisms: Enterococcus, Strep, Staph, E. coli. And if we look specifically at those organisms detected in the probable and possible categories, or in other words, what kind of organisms did Karius tests detect that were missed or not seen by standard microbiological tests? Well, those were microbes of the oral and gastrointestinal flora in 37.8% of cases, followed by Enterobacteriaceae in 21.7%, predominantly E. coli again, and gram-positive cocci such as strep mitis. The most frequent non-bacterial organisms were HSV1, Candida, and then notably there was 1 patient in whom Pneumocystis jirovecii was detected at all time points, and actually about 5 days prior to the diagnosis by standard microbiological testing. We detected invasive molds in 3 subjects, Aspergillus in 2 different patients at T1, and then Rhizopus species in 2 consecutive time points in a patient that we'll talk about a little bit later. So overall, Karius test identified a febrile neutropenia, a potential etiology twice as frequently as a standard microbiological testing, and was positive in 41 of 48 cases, whereas standard testing was positive in 20 out of 48. And when we looked at the time to diagnosis, in this graph, we have Karius test in orange and a standard microbiological test in black, and a different categorization classifications. Overall, Karius test would have detected an organism earlier in 87.3% of the cases, and that's kind of at all time points. And if we look specifically at those cases in which either standard microbiological tests or blood cultures were positive, that's for 12 cases. In those situations, even in that situation, Karius test would have detected the organism earlier in 50% of these cases. In order to further assess the clinical utility of Karius, the adjudication committee has determined as well the effectiveness of the empirical antimicrobial treatment for the organisms that Karius test would have detected. At initial, at the time of fever onset, the empirical antimicrobial treatment was deemed to be effective or likely effective in 38% of the cases, and not effective or likely not effective in 36.3% of the cases. Now, at the time that Karius test results would have been available, and that again, for this study, it's worth mentioning, it was 52 hours for most of the samples and 100 hours for those samples that require rerunning. That is different right now, but that's how it was at the time the study was done. So at that time, the committee determined that the antibiotics were effective or likely effective in 42% of the cases, and not effective or likely not effective still in a third of cases. So based on these results, the adjudication committee would have changed antimicrobials in 47% of patients. And that translates into an addition of antimicrobials in 20% of the cases, and mostly of anti-anaerobic coverage in 12.7%. They would have narrowed antimicrobials in 25.5%, and that included a 9% in which MRSA coverage would have been withdrawn. They would have added antivirals in 14.5%, antifungals in 3.6%, and then in one specific case, it would have added antimicrobacterial coverage for M. abscessus in a case in which the patient had pulmonary nodules and a compatible clinical syndrome. So to finalize a little bit, I would like to illustrate one case in which Karius test within the study would have been really particularly useful. This was a 66-year-old female with AML and febrile neutropenia. Now, on day 6, she was found to have on the CT chest multiple sub-centimeter nodules and granulous opacities, and the suspicion for fungal pneumonia prompted initiation of voriconazole. Next. On day 11, she had progressive cavitary pneumonia with parapneumonic effusion, and she ended up getting a bronchoscopy, and the bronchoalveolar lavage grew 6 colonies of Aspergillus niger, and the Aspergillus galactomana was also positive at greater than 2. Now, on day 13, she continued to have fevers, and voriconazole was essentially brought into ambisome, and she actually defervesced. But unfortunately, on day 20, she needed a chest tube for a worsening in empyema. Her pleural cultures were negative, and the 18S ribosomal sequencing was also negative. On day 25, she was febrile again, and her CT showed actually progressive abscess and empyema, now with fistulization. On day 30, she developed some encephalopathy and neurological symptoms, and an MRI showed a big ring-enhancing lesion, which was eventually biopsied on day 38. Now, fungal cultures and again, 18S ribosomal sequencing were negative, but the histopathology showed hyphal forms passing GMS positive that were consistent and possibly consistent with Rhizopus species. On day 48, she continued to worsen on radiological grounds. On day 50, actually, she ended up being changed back from ambisome to voriconazole per patient preference. Now, what it is interesting here is that on day 4, Karius test detected Rhizopus species, which is 10 days prior to the amphotericin initiation and 34 days prior to the brain biopsy results that were consistent with possible Rhizopus on histopathology. The test was repeated on day 7, and again, it showed Rhizopus species. Now, Aspergillus niger can certainly cause a clinical syndrome of lung abscess and brain abscesses, but we know that Aspergillus niger is actually a relatively non-pathogenic organism. And the clinical picture, and of course, with the histopathology seems to be more consistent with Rhizopus, so at least a possible dual infection that could have been covered earlier and with the appropriate antifungals. So in summary, compared to standard microbiological testing, Karius test was twice more likely to provide a microbiological diagnosis and often without invasive diagnostic procedures. At T1, Karius test detected nearly all organisms isolated by blood cultures, and its negative predictive agreement was only 31%, which is a predictably low proportion due to the relative lack of sensitivity of blood cultures. At T1, Karius test yielded a positive result, again, just twice as frequently, but detecting a pathogen adjudicated as a plausible cause of fever in every case. Karius test identified also very clinically significant viral and fungal infections, as well as a clinical significant polymicrobial infections that were not detected by standard testing. And the sensitivity of Karius test relative to adjudication was at 85% with a false negative rate of 15%. Looking into secondary outcomes, Karius test could have provided an earlier result in 87.3% of all cases and half of those with positive blood culture or standard testing. It would have allowed earlier targeted treatment in one specific patient with pneumocystis jirovecii pneumonia. And finally, adjudicators would have changed antimicrobial management in nearly half of the patients on the basis of Karius test results, de-escalating or discontinuing antimicrobials in about a fourth of these patients, and mostly narrowing gram-negative coverage or ceasing MRSA targeted therapy, which is pretty much a nightmare for those who know and take care of febrile neutropenic patients. Now, our study has several limitations. To start, it was a modest size and single center study. One of our main caveats was that we didn't really look into control samples prior to the onset of fever in the neutropenic patients or in non-neutropenic patients whatsoever. And we know by other studies that looking into the microbiome in neutropenic patients and the organism predominance can really predict the risk of translocation in these patients. And as a matter of fact, in another Karius test, they were able to see that when Karius test was performed 2 days prior to the onset of fever, it was able to predict and diagnose 7 cases out of 9 of bacteremia in patients with malignancy. Now, also at the time of the study, we did not have quantitative measurements of the Karius test, and thus we will not be able to determine organism predominance or the correlation of our detections based on clinical findings or categorization by adjudication. In addition to this, because we did not have the presence or severity of mucositis in these patients recorded systematically, we were not able to essentially figure out how many of, how sterile these blood samples were to start with, right? So in terms of the adjudication per se, another caveat was that we did not adjudicate each organism identified in polymicrobial detections separately. That is, for instance, if a blood culture was positive for strep mites and Karius test detected strep mites, but also aspergillus and also herpes, that specific case would have been categorized as a definite case, and therefore the other organisms would not have been adjudicated specifically for what it's worth. So another issue with the adjudication would be that Karius test results were not really blinded to the adjudicators, adding a potential for bias, even if the process by which they would adjudicate would go through first a determination as to whether the fever was deemed to be, infectious, and then they will look into the Karius test results. It was still not blinded. Finally, the classification of the adjudicated possible cases as true positives could have overestimated both the sensitivity, but also the specificity of Karius test by decreasing the amount of potential false positives. There are other limitations that are more intrinsic to the technology or to next generation sequencing. We always worry about the potential for sample contamination or the detection of background noise. Now, in the validation studies of Karius test, the analytic specificity was 99.9% after a very thorough assessment of environmental contamination, pathogen cross-reactivity, and co-infection, and diversity robustness. Another issue is because of the enhanced sensitivity and the breadth of microorganisms that Karius test can detect, the diagnostic specificity can be further compromised. And that becomes specifically a problem and challenging for result interpretation, mostly when there are polymicrobial detections or detections of commensals and oral and other flora. And certainly we see organisms that have an uncertain clinical significance and actionability. So really, I would like to stress out that this is, as Dr. McIntyre was mentioning, infectious diseases expertise is available and should be used. And these tests should be really interpreted by people with not only clinical expertise, but also certainly a familiarity with this technology. Finally, there are other limitations of the technology to the, of the tests in the routine basis, and is really as a substitute of classical methods based on certain limitations, like Karius test cannot detect RNA viruses and really doesn't provide susceptibility profiles. So additional testing may be necessary, and it limits also a little bit its use in antibiotic stewardship or antimicrobial optimization. And the last but not least limitation that I would mention is, of course, the cost of the test may be a barrier for its routine use. So in summary, and to conclude, Karius tests can enhance the ability to diagnose infections in febrile neutropenic patients, and specifically and especially in those patients in whom standard testing fails to detect an infectious culprit, or in those in whom invasive testing is really not feasible. It also may enable early optimization of antimicrobial therapy. Nevertheless, complete understanding of the utility of the Karius tests in real-world clinical practice and really its integration in the diagnostic algorithms require further investigation. We really need to find out when and how to use it. Is it earlier in the course of the infection, or should we exhaust, for example, other standard microbiological testing? From my personal opinion, one of the things that we really need to be looking at as well is kind of correlating these performances with clinical outcomes, including not only specific clinical outcomes, but things like hospital stay, cost effectiveness, and such. So with this, I will end. I will thank everyone for their attention. I will thank the study team for all the effort with this, and I will leave it open for questions.